now. We're going to then have the privilege to have here Professor Mariano Sanz, and we were talking before about prevention, and we were talking about early detection or and diagnosis of periodontal and peri-implant diseases. That is the key element to provide appropriate treatment and to have a perfect management of a patient. In that respect, Mariano has been completely involved in the development of a new classification of periodontal and peri-implant diseases. I'm going to pass the word to him, so he's going to tell us the general aspects of this new classification and how clinicians should apply them to their patients. And in that respect, a recent guide has been published also by him and Maurizio Tonetti that is telling the clinician how to apply this new classification, which has very different features as compared to the one we had previously. So please, Mariano, if you can tell us some words about this.
Well, the novelty of this classification is basically that we have tried from the beginning to develop a system that would help not only to classify patients in different entities, but also to guide therapy, to guide the management of the different entities, and also to guide the communication between the dentist and the patient, and also among the different dentists. And we have developed a system that every stage of the diseases that we identify has a system of prevention and therapy, and also a very easy way to communicate patients what the problem they have and how that problem should be managed. And I don't think we need to go into detail of the different stages, of the different processes, but at the same time we have developed a guide, a basic algorithm, so dentists can go step by step, going through any kind of patient, from those that are healthy to those that have the most severe disease. And going through these steps, I think it will be very easy to use this classification and to communicate patients and other professionals on exactly how to approach the management and prevention of these patients. So this classification is much more than a system to classify processes. It's a complete system of diagnosis and management. And hopefully, through the guide, this will be made easy for everybody to practice this new system and to implement it in our everyday practice. We have published this guide 3-4 months ago, so it's a very new implementation method, and we hope that this will be used extensively. We have done several trials in universities, in institutions, and the result has been very good. Actually, when we teach undergraduate students from zero, that is, they don't have a prior knowledge, they don't know how it was done before, then they get it immediately. It's very easy and very straightforward. For those who have been practicing the old system for many years, it's not so easy, because we need to, in a way, disintegrate what they had and implement a new system. And that sometimes takes a little more time, but we will get there. Thank you.
Thank you very much, Mariano. Thank you for the effort to make all this information easy to digest by all the clinicians. I think the guides are available on the EFP website. Is this correct?
Correct.
Yeah. So you can maybe mention that
Comment on this?
in your press note that every dentist can have free access to those guides at the European Federation of Periodontology website. So I think Professor Linde wanted to add something to the discussion.
Yeah, I'm coming back to the classification that Dr. Sanz described for you. What I appreciate very much with this classification is that there is a case definition. In other words, the dentist is forced to examine a patient and decide what type of patient is sitting in my chair. It's not only a periodontitis patient, because that sometimes you don't even have to be in the dental chair to have a diagnosis. But with this system, you as a dentist have to take a stand. This patient has periodontitis, class this and this, and that demands that I do certain procedures with the patient. That is, I think, the beauty with the new classification.
Exactly. Yeah. So thank you very much, Professor Linde, for that comment. And yeah, I think it's as I said, it's not only a periodontitis diagnosis. Some patients do require rehabilitations, and that's sometimes within one of the stages. I think it's stage 4. It's a stage in which is defined that these patients do need additional treatment.
Yeah, that's the point. I mean, there are different stages, 1, 2, 3, 4. And once you reach a certain stage, then you understand that restorative therapy is required in order to solve the case. In the old days, periodontists said, no, we are not dealing with restorative cases. But that is a must now. At least they have to make a decision. We have, for instance, the advanced cases to do restorative therapy. We can no longer only rely on dental hygiene procedures. So there is these distinctions, which I think is very good for our profession.
Exactly. So in that respect, I will connect my question to Professor Linde that, well, you know, we have Professor Linde and Professor Lang. They are the editors of the book that we all study in the postgraduate school. And it is a real honor to have them here. These are the two most relevant personalities in periodontology in the last 50 years, clearly. And SEPA feels extremely honored to have them here. And I think that you also have to feel honored to be exposed to them and to be able to ask questions, okay? They don't like to be flattered, but I have to do it because, of course, they deserve it. Having said that, okay, as I was saying, I want to take advantage of the presence of Professor Linde here to ask him, as he has been involved in the development of periodontology in the last, if I say 50 years, am I correct? Yeah, or maybe probably even more. So many of the concepts that have been developed through these years into periodontology, which it was one of the, within dentistry, I may say that periodontology was one of the first ones who started to apply a scientific method to its understanding, and these two persons had to do a lot on that. So how do you think the knowledge of periodontology has influenced the way we treat now implant patients and the way we do bone regeneration procedures for our implant patients? Has it have a big influence on it? Do you think that it needs to be even more influential? What's your opinion about this?
Well, it's quite obvious that implant dentistry, once it became related to clinical periodontology, changed. And the reason for that is that we periodontists understood very early, not every dentist did that, but we periodontists understood that the attachment between a tooth and the bone is completely different from the attachment between an implant and the bone. And therefore, this knowledge requires a certain standpoint, a certain approach to the examination and treatment of a patient. And that in itself, I think, has elevated implant dentistry to a much, much more significant level than it was when with only a question of a screw in the bone. And then you should notice that each time that Dr. Guerrero has a difficult question, he always does like this. Be quiet,
Yeah,
Jan, because now it comes.
I want you to be relaxed. Okay. But that's true. I didn't know that. So I will see in the video. Okay. So thank you very much. And but now I want to also take advantage of Professor Lan.
Touch it.
But it's too far.
Touch it.
Okay. So of course he was as Professor Linde sometimes joining forces into research projects. Sometimes each one of them, he was based in Bern. Originally he was in other positions, but his amount of research came from the Bern University and Professor Linde from Göteborg. And he has a presentation on the development of periodontology in the last 50 years. So how do you think Europe has influenced the development of periodontology in these 50 years? And what do you think it has been the influence of Spain, of CEPA, into this development?
Well, CEPA celebrates its 60th birthday. 60 years ago, our treatment philosophies, I think, through most of Europe, based on theories that were formulated by master clinicians. It was a deductive thinking, heavily influenced by the master clinicians in the United States. And consequently, people who went for training to the United States came back and propagated the respective philosophy. And there were many different philosophies at that time. Now, 60 years ago, maybe a little bit earlier, something happened that changed periodontal visions forever. And that is that in the Scandinavian countries, one changed from deductive thinking to inductive thinking. In other words, you mentioned it, to use scientific methods to test hypotheses. And that started really in Scandinavia and is affiliated with predominantly three names, namely Jens Verhaug, Jan Linde, and Harald Löö. They're all Denmark, Norway, and Sweden. And from that moment on, clinical experiments were done and improved our vision, mosaic stone for mosaic stone, to realize that we actually should follow a philosophy that is so-called evidence-based. And this happened throughout the last 60 years. And in the last 30 years, I would say, this activity has also spread towards the south. And when I say towards the south, I may mention the Netherlands, Switzerland, and of course Spain. Spain has contributed a lot in the last 30 years to the gaining of knowledge that is evidence-based. So today we don't have 15,001 different philosophies. We adhere to what we can defend on the basis of scientific evidence. And in that sense, the Americans are a little bit jealous because it was Europe that carried the torch in the last 30, 40 years. And in America, people have different paradigms. So I think we are very lucky these days to have these philosophies, or let's say these treatment concepts that do not differ so much anymore from one side to another. And they are all based on biology and on prevention of the disease, primary and secondary prevention. So if this rounds off the whole thing, I think we can be very proud of what has happened in Europe in the last 60 years.
Thank you very much, Klaus. Whoever wants to have more in-depth knowledge about this, we will have a fantastic session tomorrow that will discuss all these issues. Okay. So now I think you have to take advantage of the moment. This is an historical moment that we're living here. We have the Nadal and Federer here. I don't know who is who. Okay. And then we have Novak Djokovic here on my left. And we are just, giving back the balls, okay, on the net. So you are humble listeners.
If I could be Björn Borg,
No,
I
no,
would, of course, because
No.
he was very stubborn.
No, because you still
He
play a
could
lot.
go on for hundreds of years.
You still
No.
play a lot and you win many majors.
Yes.
Still.
Now, but may I add a little bit to what Dr. Lang said? It is not so that all Americans are treated in the wrong way. And it was not so in the old days that patients in America were not well treated. It was so that graduate periodontics was done in different schools on the East Coast, in the middle of America, and on the West Coast. And each program director was the boss. And he decided what is correct and what is incorrect. And that led to conflicts. The goal was the same, a healthy patient, but the way to the goal differed. And that created tensions, also tensions to Europe. And Klaus forgot to mention Ramfjord. Sigmund Ramfjord is a Norwegian who worked most of his life in Ann Arbor in Michigan. And he was the one who tested different treatment options and could compare which treatment alternative led to the final result in the more easy way. So that is just to clarify that in the old days people were well treated, but it became a little bit more easy when you could compare and have an open mind to different treatment alternatives.
Thank you. And isn't it so that now, now that we have the implants, it seems that sometimes the research, the clinical research has forgotten a little bit about treatments in perio. Because in the past, we used to have a lot of studies, the classical studies comparing different treatment alternatives. Now, we're doing our clinical applications based on those studies, but we don't have really up-to-date studies to get their well-designed studies with today's technology to allow for a very accurate assessment on the best treatment for our patients. When it comes to periodontal treatment, not for implant therapy, most of the researchers are focused, they're interested in there, but maybe for periodontal therapy, we still need, or we need more updated studies and more interest into that. What's your opinion? Maybe Mariano can also give his opinion on that.
Well, you said it. The classical studies, well-designed studies that tested hypotheses were done in the 80s and 90s. And ever since in this century, we have not had such studies performed on a regular basis. So you may say this is an old story, and it has been pushed away by implant research a little bit, but only a little bit. I think those who still adhere to periodontal therapy and prevention remember the old studies and every so often put it in perspectives of what we do today. So I think I look at it like a mosaic. And in the mosaic there are maybe today a few stones that are still missing, but we can very clearly recognize the image. And I think that is owing to a lot of effort in clinical research. And the implant research profited from that philosophy. I mean, before, I may repeat what Professor Linde has said, before periodontists got a hold of implant dentistry and realized that there are other chewing elements that we have to look for, the implant dentistry was dominated by mechanistic approaches rather than biological approaches.
And yet we have to accept that the vast majority of implants that are placed are very successful, and that most implant patients are very satisfied with the treatment they have received. I think that needs to be said also in a context like this.
You want to add something, Professor Sanz?
But I think the, you know, like many things in dentistry, there are waves. And the pendulum, I think, is swinging back a little bit. I think the end of the 90s, the 2000s, we were all enthusiastic by the big success of implant dentistry. And most of dentists, or many dentists, when they had a periodontitis patient and they needed to make the decision whether to do full periodontal therapy or extraction and placing implants, decided to place implants. But I think the pendulum is swinging back because many of us and many dentists around the world have seen that mostly in periodontitis patients, when you place implants, the number of complications is not low. It is relevant. And the more implants you have placed in periodontitis patients, the more problems you are going to encounter in your own practice. So now many dentists in the world, when they are looking at a periodontitis patient, are thinking perhaps it is worthier that I do full periodontal therapy and try to maintain those teeth that, of course, have been affected by periodontal disease. And I believe that there is a lot of more attention now in the ways to treat periodontitis than it was 15 years ago. And in that sense, I think we need to follow a very famous sentence by Professor Lang saying that implant therapy is a fantastic tool to replace lost teeth, but it's not a tool at all to exchange teeth for implants.
Thank you very much. So I think this is a good ending message that it's extremely important with a clinical relevance that of course implant therapy is there to help clinicians and patients to replace their lost teeth, but we should not extract them to place implants. This is quite clear. So I will open the session for questions, and so if you have any questions here, we'll be more than happy to approach them.
Tell them that they can do it in Spanish.
Sí, puedes hacer you can do it in Spanish the questions if you want. I can translate.
Hola, soy Emi del Dentista Moderno. ¿Se oye? Sí. Considerando el estudio que ha hecho el doctor Mariano Sanz y teniendo en cuenta que la SEPA ya tiene 6.000 asistentes de diferentes disciplinas, bueno, especialidades odontológicas, ¿es posible que en un futuro no muy lejano podamos ver asistentes de otras especialidades médicas como cardiovascular, bueno, y de las que al final la periodontitis está tratando y abarcando?
Yo creo que el mundo, quizás desgraciadamente, pero el mundo de la medicina y de la odontología cada vez está más especializado. Cada vez conocemos más de un terreno más pequeñito. Entonces yo no preveo que el mundo de la medicina, que tienen sus congresos, sus actividades, emplee 4 días para venir a un congreso odontológico. Lo que sí que preveo, cada vez con más interés, es que dentro de un congreso como SEPA se organicen sesiones de alta calidad enfocadas hacia cardiólogos o hacia... Y probablemente no vengan muchos, pero sí que podremos invitar a los más relevantes para crear documentos que luego puedan ser distribuidos y leídos a gran escala. Yo creo que en este sentido, un congreso como este, con este potencial, puede tener la capacidad de crear centros o lugares de interés para crear documentos que luego puedan ser documentos o vídeos, imágenes. El mundo de la comunicación hoy en día es muy eficaz.
Sí, profesor Sanz, me gustaría preguntarle si la nueva clasificación va a influir de alguna manera para evitar esos problemas que tiene esos problemas de periodontales o perimplantarios.
Bueno, yo lo que creo es que lo que nos va a ayudar no es tanto a evitar los problemas, pero sí a mejorar mucho nuestra comunicación. Es decir, el sistema que hemos creado no es un sistema que hayamos inventado después de una noche de lucidez, no. Es un sistema que hemos un poco importado del mundo de la oncología. Y el mundo de la oncología lleva muchos años comunicándose entre las distintas especialidades oncológicas para saber en todo momento cuál es el pronóstico y cuáles son las vías de tratamiento. Si les pongo un ejemplo, todos tenemos familiares que nos dicen: yo tengo un carcinoma estadio 4. Y ya sabes que el estadio 4 va a ser muy difícil de resolver solo por la excisión quirúrgica. Y hay una comunicación que abarca no solo lo que el médico escribe en su fichero, sino lo que el paciente entiende. Y también todos sabemos que en el mundo de la oncología establece grados de agresividad dependiendo de las células. Y algunos, si tienen una agresividad, pueden someterse a inmunoterapia, otros radioterapia, otros quimioterapia, etc. Y han desarrollado un sistema muy fácil para comunicarse entre sí. Eso es lo que hemos tratado de hacer nosotros. Y hemos reproducido los estadios, los grados, para comunicar al paciente la agresividad del problema y la severidad y la complejidad del problema. Y al paciente le podemos decir claramente: mire, usted tiene una periodontitis estadio 3, que se puede resolver con tratamiento periodontal, pero va a ser un tratamiento complejo, porque el tratamiento simple resuelve muy bien la 2, pero no la 3. Y eso es lo que hemos tratado de hacer. Ahora tenemos que implementarlo para que, como ha dicho el profesor Linde, todos los dentistas lo acojan y forme parte de cómo examinan y evalúan a todos sus pacientes.
Quería, doctor Sanz. Ahora sí. Quería profundizar un poco en el tema de la nueva clasificación. Es verdad que está recién lanzada, pero ¿cómo ha acogido la comunidad odontológica esta nueva clasificación? ¿Y cuánto cree que va a tardar, después de tantos años implementada la anterior, en calar entre la profesión dental?
Hombre, yo creo que I will say it in English. So I think that the new classification is being implemented at the same time in Europe by the EFP and the national societies, SEPA in Spain, for example, and in United States by the American Academy of Periodontology, and in all Latin America by all the societies in the Ibero-Pan-American Federation, in Japan by the Japanese Society of Periodontology, etc., etc. So we have a concerted action all around the world to go at the same time implementing the classification. Here in Europe, we have even developed a method to do it step by step. So it is easy for the dentist to start from the beginning. We have tried the method before implementing it in the universities. We are trying to validate it. So we do it in different universities at the same time with the same set of patients. Of course, not the patients, but the records of the patients. And we are in the process of doing that. The preliminary results that we have done have been very good. Mostly, as I alluded before, when we have tried it with dental students that did not have prior knowledge of the old classification.
So Professor Linde wanted to add something to the discussion.
I think what you should also understand that this case definition or classification system will make it easier to understand different type of results presented, for instance, by industry. Let's now say that an industrial company comes out with an advertisement saying that this particular mouth rinse, or this particular dentifrice, or this particular toothbrush is very effective on periodontitis. Today, Mariano, I think they have to say it's effective on periodontitis classification 1 or 2, but not on 3 or 4. So that may clear the deck for also the public, not only dentists and dental hygienists, but also for the patients to understand what type of products that they can use for what.
Thank you very much. This is an amazing contribution, and it is extremely important for all the companies that we have here.
Yeah, of course.
And of course, at the end, the one getting the benefit of these messages is the patient that knows what's going on and what are they buying the products for.
And it means no more nonsense. Tell us, when does it work and when doesn't it work? That to me is important.
Any other questions? Daniel, question? No?
No more.
Okay, so I think well, we have the last question here.
Spanish or English? Professor Jan Linde, what is your opinion about the new classification for gingival resection? Well, it's a great change about 1985, Miller, and now Cairo. What's your opinion about it?
You know, I have reached an age now where I'm retired and I don't have to have an opinion of everything any longer. So I leave that to Dr. Lang or Dr. Sanz, who are still active, to answer that particular question.
Well,
Somebody in the panel that is not retiring?
well, there was a lot of discussion in these groups why they changed to the Cairo classification and why they adopted that. I think there were good reasons for it, and I'm not the one to judge whether this was correct or not, because I was not working in that group. Neither am I the expert on recessions.
Yeah, but if we have to give a message,
But if I can,
I think once you have such a universal classification that has been discussed at large and comes out in a way that it is concerted throughout the world, I think we should not go back to previous classifications because we will confuse the issue.
sorry about the question, but we, if we go to our students and we say that Nicolas Lang said us that he wasn't in this group and Professor Linde he will be retiring, well, the students will have a lot of doubts.
Now, why don't the students go with the new classifications? It is irrelevant of what I say here. I think this was the working group who decided to propose that new classification. So I think we should work with it.
Yeah, I think Professor Sanz can add. He was involved in the design of the workshop, and he knows.
My first comment is that this was a world workshop who defined the conditions, diseases, and their classification. So it is not the classification of a person. So the first thing we need to do is that we need to avoid names with the classification. This is the classification of the workshop on the mucogingival conditions. And I think the important thing, again, is not how we classify the conditions, but how we make the system to approach the treatment. So in that sense, the classification has produced a matrix with several factors. Of course, one of the factors is the extent of the interproximal tissue height in relation to the recession. But this is only one factor. There are many other factors in the matrix that really help the clinician to undertake the appropriate treatment direction. And I think this is a great innovation. I don't think probably in a press
12:30,
conference
but it's on
is
the
the
other hall.
space to discuss the technicalities. But I think we can say that in the classification of the mucogingival conditions, I think there has been a great improvement.
Bueno, muchísimas gracias a todos por vuestra atención, vuestras preguntas y vuestro interés. Y thank you very much to all of you for your time and your contributions. For CEPA, it's an honor to count on these top three, as I said, with the Federer, Nadal, and Djokovic of the perio world. And I hope you have all enjoyed it. And I also sent you a message of joy and of taking advantage of the whole Congress. We are starting right now, and big sessions are starting at 12:30. So enjoy a lot and see you around. Thank you very much.